You look like a man with a real job. What's up? How's it going?
Great to see you.
Good to see you.
Great to see you.
How's everything?
Yeah, I got a real job. I just came from the job. So
Yeah, I understand you've had a busy day.
had a busy week.
Yeah, don't you always?
Yes. Never changes.
Well, I'm glad to see you. Thank you so much for doing this. So how you like the man cave here?
Hey, I like it. I like it. I was just saying, my shop doesn't look quite this good.
Yeah, well, I borrowed Robin's car. I had my 57 in here before, but I pulled Robin's car in now, so it looks a little fancier.
57.
A 57 Chevy.
Chevy. Really?
Yeah, I'll have to show it to you.
Hardtop?
No,
Convertible?
convertible.
Oh.
Black, red interior.
Oh.
I had everything in its stock until it got stolen, and then I got it back. They actually
Really?
recovered it, so it got trashed. And so when I started redoing it, I thought, yeah, what the hell? So I took the engine out, and I'm now running about 700 horsepower with Flowmaster L48 headers and all, and it's really a lot of fun.
I didn't know you were a hot rod guy.
Oh yeah, it runs on pure testosterone. You don't even put gas in it. So, well, are you curious why I wanted to talk to you?
Well, you gave me a little idea.
Of
Is that you
course
think
I
I
did.
do something unique, which
I don't think you do something you did. Come on. I mean, all humility aside, my goal in doing this podcast is I want to talk to the top experts in the world. I want to talk to the people that are the best at what they do. You know the regard with which I hold you, and you know what role you played in my life and my family, both directly and indirectly. But I first wanted to know about you because you're always behind a mask. People don't see you, and usually we're rolling into the operating room and we're unconscious within seconds, and then you take our bodies apart and put them back together again. So I want to start out by just talking about you, and I want people to know, because you have a very interesting life aside from just what you do in medicine. Where'd you go to medical school first?
I went to medical school in Oregon at Oregon Health Sciences University in
Right.
Portland, Oregon.
Right. Where did you do your residency and all of that?
I came to Los Angeles, did my residency at UCLA. Then I finished college, finished medical school. I did some graduate work and research, and then I started my residency.
Oh, you actually did research before you went to your residency.
Yes.
What was the research in?
Endocrinology of how the brain works.
Really?
Mm-hmm.
Then you started your residency, and that goes 6 or 7 years. What do you do your first year different from what you do in your 6th or 7th year?
Your first year, you get to run around and do all what we call the scut work, and you get to take care of patients, and you take care of all the administrative and paperwork. You get to go see patients when they come in the emergency room, and you get to go see them on the ward, and you help out with the doctors. But it is like an apprentice. And each year you have a graded advancement in what you do in your responsibilities. And you go to the operating room a little bit when you're an intern and a first-year resident. And each year it's more responsibility, and you get to the end where you're supposed to be able to be a functioning and independent surgeon all by yourself. That's the goal.
By the time you finish that, how many procedures have you done over that 6 or 7 years?
2,000 or 3,000, depending on the
2 or
residency
3,000.
program. Yeah.
I think people don't know this, and that's what I think is so interesting. As you say, you finished your college, you finished medical school, and medical school took you how long?
4 years of medical school, and I did a few years of graduate research mixed in with it, so I spent a couple extra years.
Okay, so 6 years, then you spend 6 or 7 years, and you've done 2,000 or 3,000 procedures. When I say done, I mean, some of it was you're a potted plant in the room to start with, and you're handing them stuff and watching, and then it gets more and more and more as you go along, right?
That's correct.
So even when somebody walks in to a freshly minted neurosurgeon that has gone your track, they have been through 2,000 or 3,000 procedures by the time that first patient walks in. When you started your practice, where did you start it to begin with?
I started at UCLA, and I worked at the county hospital. I also worked at the VA. So I had a job with several different hats.
Yeah.
And so it gave me a lot of diversity.
But when you started out and you knew you were new, there was a day where you woke up and for the first time you were in practice for yourself, right? There was a time where you picked up that knife and everybody was looking at you. There was nobody else to look at.
That's correct. Actually, the more frightening component of it was I turned around and looked behind me and said, there's nobody here to back me up.
Did that moment hit you?
Yeah. Oh, yeah, it certainly does. In fact, as you go through your first weeks, months, and even into years, you kind of turn around and you look and you say, gee, where's that guy who was helping me out, one of my professors, as I wish one of them were here right now, when I'm in a tight spot, and things are not going well or something's more challenging than I'm ready to handle.
So what do you say to yourself in those situations?
My gosh, you got to figure out how to do it.
Yeah.
Yeah. Well, that's why you have partners. When you go into practice, some people do go into practice all by themselves and solo, but they will have other surgeons assist them.
Right.
So if somebody goes out into practice, they'll have one of the older surgeons come with them and they assist because you really need an assistant. You need a third and fourth hand, and I only got two. So that's how a lot of guys do it that are out in practice. If you're at a university or your big programs, you have other people, and the mentoring, it continues.
And it is very collegial like that, right?
Yes, it does.
I mean, you guys really do. It's not competitive, it's collegial.
Correct.
You have been so great in taking care of me and my family, and at times it's involved other hospitals and other doctors and other specialists that don't practice where you do. And I listen to you guys talk, and it's like you went to high school together. I mean, it's like instantly everybody's pulling in the same direction. Everybody puts the patient's interest right up front, right in the beginning.
That's the way it's supposed to work.
Well, it does with you.
That's
But of course, I do have Pat Johnson calling. That does help. Come on.
Well, to quote my brother, he says, you reach a stage in life that you don't have competitors, you just have colleagues.
I can tell you from a patient standpoint, that's how it looks. Don't want to embarrass you, but you are certainly well regarded among your colleagues, I can tell you.
It makes what I do fun. I don't really have what I consider challenges anymore. I consider the operation that I did today, it's some incredible operation that it's just not done many places anywhere in the country or the world, and it's like, we just have fun doing them.
Obviously, without violating any confidences whatsoever, give us an overview of what you did today.
I did an operation on a colleague in my industry, actually, who came to me about a year ago, and he had a problem in his neck and he was going paralyzed from it. He had a problem that likely dates back to when he was a college athlete, and he probably had a fracture in his neck, and he had this funny deformity of his neck where we call it a swan neck, where the vertebra actually kind of had this curve. And even though we operated on him 8 months ago and he got better, he was still having problems because the curvature created a stretch of his spinal cord. And so the spinal cord is on tension. So we had to actually go in the back of this guy's neck as a first stage. And then a second stage, we went in the front. And then the third stage, we went in the back. So I explain it to people, and I'm very candid about it. I say, in a very controlled way, we had to break his neck in a couple places, and we had to straighten it back out and do some reconstruction on the back side, the front side, and then go to the back side. We did 3 stages.
Do you expect to have a resolution from that?
I think this guy's going to get better to the point that he can function. I'm not sure he's ever going to go back to practice, but he's going to be able to walk and take care of himself, and he's going to go back and do his research work. He's got another career, which he's going to be able to pursue. I'm happy for him that we could help him out, and time's going to tell over the coming months.
We live in LA. What difference does it make to people living in this market versus somebody living in a rural market if they have a major acute problem in terms of life expectancy?
What's great about this country is that we have such an incredibly high level of care almost everywhere. I would say for about 95% of problems that occur, most every reasonable sized city of 50, 70, 100,000, there's great quality care. There really is. We're just so fortunate in this country. That doesn't exist in Eastern European countries. I know, I've been to those places.
How many surgeries have you done, would you say, in your career? Do you keep a tally?
I think it's top 10,000 now.
Over 10,000 times you've cut people open.
Yep.
And they've not all been brain and spinal cord, correct? You've done some heart work as well, right?
Well, when I was in training, I did all that stuff.
Yeah.
Yeah, I learned a lot. I had fun. It was a great experience growing up and going through that and seeing all of these different things and learning.
Do you ever wish you were doing a different kind of surgery, or are you totally passionate about what you're doing now?
I am completely happy that I made the choice that I did.
Yeah.
Because when I was young and thinking about where I wanted to go in medicine and what discipline, I thought I wanted to be a cardiac surgeon.
Uh-huh.
I did a lot of it when I was in training at UCLA, and I had the opportunity to work with the top people in the world, and that's who inspired me. There's some
Right.
guys there that just inspired me and says, I want to be like them.
Yeah.
These guys are incredible.
And you did a number of open heart surgeries that you were involved in there, correct?
I got the opportunity to work on the cardiac service there and open people's chests up, which when I was a young resident, you usually didn't get to do, but just I was in the right place, the right time, and I got to do a lot of big things, outside of my intended discipline,
Right.
which was just an incredible experience.
You work on the spine, and you've worked on mine in different ways, including surgery, very successfully, I might add. I know I'm not the best on follow-ups. I mean, everything's working, and in record time, actually. Do people wait too long? Generally, when somebody comes into your office, are you looking at them thinking, you're here too early, you're here too late?
It's not very often that I say that somebody came in too late. Occasionally. I got a few of them that are going through my mind right now, and but I would say that people have had enough awareness. I think things like the internet have made just the awareness of what people are. If somebody has problems walking or their arm doesn't work or something, and pain is usually a big motivator as well, but not everybody has pain.
I was not having pain when you operated on my neck. I wasn't having pain, but I play tennis every day. It was my left arm. I tossed the ball, and all of a sudden I was like throwing it over the fence. Then I was throwing it over here, and it was like the nerves were working and then they weren't working, and I didn't have the control. And then all of a sudden the arm looked like it was withering. It was starting to atrophy. And it started happening really fast. That's when I called and said, well, what the hell's going on? And you were on it pretty quick. You recall I came in after taping one day. You said, I'll give you one more day, but then you got to get in here and do it. Was that pushing too late? I mean, should I have been there sooner?
You probably fall into that category a little bit.
Yeah,
I was going to ask you, how's your tennis game doing? So,
Yeah.
you tossing the ball okay?
Well,
it is your left hand.
I've had to retrain it. That muscle memory really got disrupted and went away.
Yeah, I'll put you into the category of one of those that waited a little long.
Yeah, maybe.
When you come in and the arms, the shoulders lost some muscle and you're having a hard time holding it up. And I said, you probably need to come see me a little sooner.
You guys are doing some amazing things right now that I want to talk about with regard to ALS and stem cell. Can you talk about that a little bit in a way that people can understand it?
ALS is a disease, Lou Gehrig's disease, where there is a loss of the neurons inside of the spinal cord. And so people have an inexorable progression to death. And from the time of diagnosis, it's 1 to 3 years, and most people are dead. There are some people that have lived a long time. Stephen Hawking lived decades.
Mm-hmm.
I'm not an ALS expert. I'm a neurosurgical expert, and we have an incredible team at Cedars, which I have to give credit to Clive Svensson's a brilliant scientist, and the work that he's done in his laboratory literally over the past decade. This started back in the early 2000s, that regeneration of things with stem cells. And we're doing things that we couldn't even talk about 10 years ago. Okay, we're putting genetically engineered fetal stem cells into the spinal cord of people with ALS. And we are following them now for the following years that they're going to be alive. And then we're going to study their spinal cord after they pass away. And we're looking at the next steps. The next steps are we're injecting stem cells into the lower spinal cord of people that would affect their lower extremities. We're looking at a next phase of either doing it in the cervical spine, which would affect their upper extremities, and also breathing.
This is an exciting time to be in your field. You're really able to do some things now that weren't even conceptualized 10 years ago.
As of right now, there are 2 institutions in the United States that are doing it, and I'm fortunate to be here and have the opportunity to work with an incredible group of people. This is not me individually. I'm the surgeon. I'm the delivery man.
Yeah.
And I got great people. It takes not just a village, it takes an army. It truly takes an army to do these things.
We're in an opioid epidemic in America right now. Are there things that can be done, need to be done to stem this tide? Are doctors giving these opioids too freely? I was looking at some research recently that said there are currently enough opioid prescriptions written for every man, woman, and child in America to have their own bottle. And that if you're taking these opioids 7 days after they're prescribed, your chance of being addicted at 1 year is 12%. If you're taking them 30 days after they were first prescribed, your likelihood of being addicted at 1 year is 31%. What do we do about this?
It is a huge problem. And you have an incredible number of statistics that are more detailed than I know. I do know that as a surgeon, it's a very small number of surgical patients that ever become part of that addiction population. Okay, I operate on people every week, and we treat them with opioids, and we carefully monitor them, but it's not that we have this overwhelming worry that we're going to be creating all the next new addicts. We really don't. It's something that when somebody has an injury, they need an operation for it, or they have any kind of malady that requires some type of pain relief, it's really infrequent. And you probably know the numbers, it's some very small single digits. It's 3 or 4% or something like that.
I know when you did my cervical surgery, I was on pain medication in the hospital. And then the next day, I think I took like 1 pain med and divided it, split it up during the day, and took Tylenol in between, something like that. And then from there on, it was just Tylenol because the pain's short-lived. But those with chronic pain, it's a different situation where they're having to manage it. But there are these pain clinics where you don't have to have an x-ray, you don't have to have a referral. People go in and they're just pill mills. And I think a lot of people think that don't go to those, but they get them from the doctors, they think, okay, I got this from a doctor, so it's okay. But your body doesn't know whether you got it from an alley or from a doctor. And then when they switch to heroin, they don't know what they're getting. Now you are getting it from an alley, and so you don't know what's in it, and it's very dangerous.
I would bet you that a lot of the prescriptions that are written are done for pure financial gain, that people will have some of these little clinics that sit in places and people get prescriptions. And if you pay somebody enough money, you'll get a prescription.
You've had a few surgeries yourself.
Quite a few.
How many times have you had your shoulder operated on?
Both shoulders 5 times.
Both shoulders 5 times?
A total of 5 for.
Yeah, and so what does this come from?
Injuries as high school and collegiate athletics in the right shoulder. I had a cancer in my shoulder one time when I was in my 30s, and then I had a rotator cuff in the other. So,
what athletics did you play in college?
Football and basketball all the way through graduate school, medical school at a collegiate level. When I was in Oregon, we played all the small college teams.
I have to ask you about this whole controversy now of the brain injuries that are associated with the head trauma from sports, not just football, but primarily football, and what we're finding on autopsy from a lot of the NFL players that have had these injuries across time. What do you think about that? Is it overstated or is it a legitimate issue?
I don't know if you know, but I actually work for the NFL as a sidelines concussion doctor. And so I'm seeing it on the weekends, and I believe that it's a real problem, and it's something that is not going to go away. And I believe that changing the game is one of the ways that I think this is going to be addressed. And some of my colleagues that I trained with are finding things that are markers that are in the blood. Just like if you had a heart attack, you can do a blood test and you can say those enzymes are up and this guy's having a heart attack, that you can do the same thing with brain injury. This stuff's on the way.
Well, let me break this down for a second. So a player gets their bell rung on the football field enough that they're slow getting up. So the rule is now they have to come out for one play. So they come out, and if there is concern that they may have a concussion, there now is a little tent set up on the sideline. What happens inside that tent that we can't see on television?
We give them basically what's called a mental status examination. Where are you? What are you doing? Who scored the last time? Who did you play last week? You know, things that they should be able to answer like that.
So at that point, they're not going back in?
They're going to the locker room, and actually we go back there and we do a more detailed test. We do a physical examination. We do things where they actually have to balance on one foot, and a whole various battery of tests that we have them do.
And if they get in the locker room and you can see clearly that they've had a concussion, what's the protocol? What happens then?
Well, they end up in a protocol which is for the following days and may turn into weeks. And it depends on, you know, the injury they had. They'll go see a neurologist who's actually part of the team physician staff. They have systems that are set up for them to be able to be evaluated. It may involve scanning their brain with CT and MRI and things like that if necessary. A lot of it comes down to just some of the cognitive testing. And that's really where the subtleties occur, that you can pick those things out. And, you know, they have baseline neuropsychiatric testing for all the players at the collegiate level, and it's reaching down into the high school level now.
Now, you just said something that's very important. So they are getting a baseline.
Correct.
What are they looking at?
It's mostly a memory testing is what it is. Some of it's actually pretty hard that I think I have a hard time doing. They'll read to you different things, you know, a wallet, a pen, a football. You know, they give you 10 different objects to remember, and they say, remember those things. We're going to come back after we go through all this other testing, and they have you repeat numerical sequences back and forth. So a lot of it has to do with short-term memory testing. There have been some big changes in the helmet technology, and only about 60% of the NFL players will use this newest helmet technology. And if you look on TV, you say they've got these things that they look different, they're bigger, they have different technology inside of those helmets, but not all of them are using them, which is surprising.
When I practiced, a lot of my focus was brain and central nervous system, closed head injuries. So I get a lot of people that know that asking me now, should I allow my sons to play football in high school? How do you answer that question if somebody says to you, should I let my son play high school football?
Need to be realistic about what are their skills. Is it something that's going to help them advance their life? If somebody is able to go to college because they play a collision sport, and it's going to allow them to get an education that they wouldn't otherwise, I can justify doing that one, just because I think the risk of those injuries with changing the equipment and the game, the way it's played, I think it reduces it significantly. People can fall off their bicycle racing a bicycle and they can have injury. Every sport that exists has the potential. It's just such a hard one to get out of our culture and our society. I mean, tell the Europeans not to play soccer.
Had it not been for college football, I would not have gone to college. And my football career was ended because of a head injury, because I couldn't play football anymore. So I took up tennis and got a tennis scholarship. But I think there are about 5,000 to 7,000 professional athlete jobs available in the United States. That's not a lot. The chances are really slim. It's a very steep pyramid. So is it worth it? What is the likelihood that I played in grade school, junior high, high school, and college? What's the chance that I got through there without having a brain injury? Is that a risk-reward ratio a parent should take?
I think it's part of our culture. I'm not sure how you can break that. You know, I think that sports and activities or things, those kind of things are what make us who we are. So it's hard to tell people not to do that.
There's been a lot of research about when people have a herniated disc, whether operating on it helps or doesn't help. Do you operate on that or do you not?
Wow, huge question, which comes down to multiple variables. In fact, my philosophy is unless somebody has debilitating loss of function or they have intractable pain, you leave it alone as long as you can, because a lot of them do get better. Probably more of them get better than people realize. I mean, the general public out there thinks herniated disc, I got a serious problem and I got to have something done about it. And actually, sometimes the less that's done, besides taking some anti-inflammatory medications you can buy over the counter, is the best thing you can do.
Mm-hmm.
And I tell people, stay away from surgeons.
Right. You remember I had disc in my low back. I remember when you first looked at it, you went, oh. But you recommended not surgery, you recommended epidural injections. You said this could last for a year, and it'd come back, and it'd last for another year. And it happened exactly that way. Then it just went away. And I still play tennis every day and do all of those things. And it's not been a problem without the surgery. So that's a perfect example of what you're talking about.
The body heals itself. The body's an amazing thing. You know, God made an incredible machine.
Right. But when you do operate, at this point, the technology is advanced to the point that you truly can help people immensely when you go in and clean up and free up the nerves. But this has truly advanced immensely in the last 20, 30 years.
Absolutely, it has. And there's a number of reasons why. The imaging technology to be able to see inside of the human body and understand what's there. MRI scanning didn't come into existence until about 1985, 86, which is when I was finishing medical school. And then we've learned how to understand what all the changes that take place. We know what the normal body looks like, and then which ones are going to get better, which ones aren't going to get better. The surgeons have gotten better and better. The technology that we have available to fix problems has gotten better. We do things like artificial discs now, and I ran the first trials here in Los Angeles, and we're just starting to understand how to use them now, 14 years later. So we've got a lot of technology. We're still learning to use it in the right ways and where, when, how, and why.
Where is this field 10 years from now?
Oh boy, that's a hard question. It's a very hard question. Because people are getting older and their expectations are greater, people don't sit at home on the porch and watch the cars drive by and the kids play in the yard. They want to be out, they want to be functional. And so it puts an enormous amount of pressure on us as surgeons to be able to perform supposedly miraculous things. I'm not answering your question about where we're going to be in 10 years. I'm going to try and get to that. But I think we have to develop some newer technology to avoid doing fusion operations in the spine. I did an operation in you without fusing your neck.
Right.
We're starting to do artificial discs in those situations now. I mean, we can do it the front, the back, we can do different operations, but it's how not to fuse the spine, because once you fuse somebody's spine, it changes the mechanics and they start wearing out the next vertebrae, and it's an inevitability. It's going to happen. That's one of my biggest misgivings is that, I train a lot of young surgeons, and I've trained over 70 of them that have gone out in the country and the world. I wish I could train 700. Make huge differences. That's what I really wish I could do. I don't have enough of my tentacles out there to influence people as much as I would. I just, not that I know more than all my colleagues out there, but I really think that taking a kinder, gentler approach
to doing spine
approach. Surgery, it is. How to do the most for the least is what it's really about to me.
Do you think we're going to get to a point, particularly with imaging, where you're going to be able to do some of these things with less insult to the body?
We're already doing it. I mean, you hear about it in spinal surgery that minimally invasive is the new thing. And what it does is Really, it's doing big operations through small incisions.
I've wondered sometimes if medical technology is moving so fast that medical technology is outstripping morality. And what I mean by that is, are we keeping people alive today that it's inhumane to do?
I think it's a practical thing, is that we have the ability to keep people alive, which it comes down to a quality of life. I think that we also have a lot of knowledge, we have a lot of insight, we have a very sophisticated society. I believe that people should have those decisions made. I think that's probably one of the answers to your question, is that should we be doing it without somebody's consent? I think that having a will, having a decision-making process of what somebody wants is certainly a way to deal with that.
When I worked as a litigation consultant, back when I had a real job, I actually did not a wrongful death, but a wrongful life lawsuit that I was involved in, because parents had a child and they knew the child had serious birth defects, and they said, we do not want you to do the extraordinary measures to keep this child alive at birth if that's what it comes down to. They did so anyway. And so the child lived for like a year and a half, horrible existence, a suffering existence, bankrupt the family, the child suffered, and they sued the hospital for wrongful life. I mean, that was what really raised the question with me, is there a point at which, science outstrips morality?
That's practicality.
Yeah.
I mean, that's practicality. And I think there are people involved in medical ethics who really need to help solve those specific kinds of problems and give us the answers. And yes, I have my own strong views about it as well, is that there certainly is a limit.
Well, I don't know the answer, but I do recognize the question, and I think we're going to face it more and more as science progresses. Dr. Pat Johnson, thank you. I cannot tell you how fascinating this all is to me and how much I appreciate you taking the time.
Well, it's truly an honor to be here, and
well, I appreciate it. Thank you so much.
Enjoy your friendship.
Well, I'm the same way. I appreciate it. Thank you so much. Phil.